delirium is basically a disturbance in the consciousness and orientation. So it's mainly a disturbance of consciousness and orientation. Whenever people stop alcohol, you know that they start having withdrawal features like tremors. So when tremors are combined with the delirious picture, it becomes something we call as delirium tremens.
Good evening, everyone. Today we have Dr. Sarthak Kamath, and who is a psychiatrist. So the topic which we are going to deal today is the delirium, which we have decided. So yes, sir, over to you, sir.
Yeah. Okay, so today's topic is delirium. So see, in psychiatric emergencies, delirium is also one of them, and there are some others like suicide and all. Okay, so first, before getting into what is delirium, let me tell you certain other words they use for that. Like you might have heard these words frequently, like ICU psychosis, organic brain syndrome, sundowning, then encephalopathy, things like that. So delirium is one of the other names for that. Okay, so delirium is basically a disturbance in the consciousness and orientation. So it's mainly a disturbance of consciousness and orientation, which is the main finding. Along with that, there are certain characteristic findings. So I'll be talking about that in clinical features. Okay, so the single most important risk factor for delirium is being elderly. Like around 70 to 80% is the risk in elderly. That too, in the elderly, they say it is much more common in people who have either urinary tract infections or pneumonia. Okay, and they say that admission itself is some amount of a risk factor for developing delirium. Okay, so like the inpatients, they say around 15 to 30% they have a chance of developing delirium. Okay, along with that, same thing with people who have undergone mainly surgeries like these orthopedic surgeries, cardiac surgeries. Those are the main things, and other than that, other surgeries as well, like whatever the generals, and also admission in the ICU is what increases the risk. So that is where the term ICU psychosis came in. So people always get confused with this term. Okay, so it's not actually a psychosis, but it's actually a delirium. So later I'll tell you what are the differences between proper psychosis and a delirium. Okay, so as I told, also in the elderly people, and more that too when they have infections, it is increased. Okay, so now let us move on to certain risk factors. So like I said, one is age. So usually more than 65 years of age is a very significant risk factor for delirium. Okay, and see, another thing that happens in surgeries is usually it is orthopedic and all. What happens is we advise them to take bed rest for some time. So what happens is when they're immobilized, they're not able to do anything. So what happens is they feel this incapacity, loss of function, that they're not able to perform as well as before. And in addition to that, there are in addition to that, there are other things like pain, and certain times, for the pain killing, they'll give sedatives like opioids and all, because after surgery, usually to prevent the severe pain, that's what they give. Okay, and see, initially in people who underwent cataract operations, they used to do for both the eyes together. But then what happened is there was a thing called black patch syndrome. So this is what is the delirium that occurs in the people who don't have any sensory stimulation. So after that, that's the reason why nowadays you see that whenever there's a cataract surgery, they operate for one eye first and then for the other. So similar things have also been seen in people who have hearing problems, mainly this sensory neural hearing loss, more of the profound hearing loss, because see, the brain actually has the thing that if there's no stimulation, it will make you see or hear things. So that is how the brain actually is, because it always needs some amount of like input. So that's why. Okay. Other things are, like I said, pain and various drugs that the people on, like opioids, anticholinergics, corticosteroids, things like that. So these are some of the important risk factors, what we call as predisposing factors. And then there are certain precipitating factors that means like if there is kind of dementia, if there is, like I said, various drugs that are used, or pain, sepsis, shock, then anemia, all of those things. Okay, so this is mainly the risk factor for delirium. Now I'll simplify the causes by writing it in the form of a mnemonic. Okay, so if you consider D, so D deals with drugs. So the drugs which are known to cause delirium is, like I said, corticosteroids, anticholinergics, then certain hypertensives, like you had the old antihypertensive called reserpine, and some of the central anticholinergics like alpha methyl dopa, they are known to cause delirium, and some of the other causes like propranolol, which is a non-selective beta blocker. So as far as other drugs are concerned, they seem to be pretty okay in delirium. Stuff like calcium channel blockers and the other usual drugs that you use. Other than that, we have antimicrobials. It can be like antibiotics or antifungals, whatever you use as an antimicrobial. Also, along with that, anti-cancer agents. So a lot of anti-cancer agents are known to cause delirium. So these are some of the few drugs. Okay, so E is, like I mentioned, eye-ear occlusion, where there is sensory deprivation which can lead to delirium. Okay, so L is low oxygen. So, a lot of causes of low oxygen, like, for example, a simple thing as an MI, or like CCF, where the adequate oxygenation is not occurring to the brain. So those things can cause delirium. And other respiratory causes like asthma, especially when there is this acute, that status asthmaticus, we call it as, the acute exacerbation of asthma. That time, a delirium is likely. Other things are COPD, pulmonary embolism, stuff like that. So see, anytime you have a cancer patient or a person with a prolonged immobilization, always be aware of this one, the pulmonary embolism, because see, prolonged immobilization, it can lead to a thrombus in the deep veins, which can again throw an embolus to the things also. So it's always necessary to look at the oxygen saturation of people whenever they present with this. Okay, so I means infections. Like I said, pneumonia, then UTI, and various other infections. What we call as sepsis, generalized infection, those are more related to this, because they say that when there is some kind of systemic inflammation, your blood-brain barrier is breached. So once the blood-brain barrier is breached, the inflammatory reaction starts. Mainly you have your microglia, and also they are the ones that cause the problems. Okay, that is I. Then R means retention, like retention of urine and stools. Just maybe a few years back, we had a patient who was actively delirious, and later when we saw, the thing was there was retention of urine. So then what happened is they immediately catheterized him, after which he was able to clear the bladder, and also the delirium stopped. Okay, that is R. Then again, I is infection. That is the same, I. And U, there is nothing. And M is metabolic complications. Okay, metabolic can be anything, right from your hypoglycemia and diabetic related complications, like you have those hyperosmolar states and stuff like that. Including that, it can be anything like even your sodium or any other electrolyte imbalance that is there. Okay, and I forgot to tell you is intracranial. So like any intracranial cause, right from even your dementia. So what dementia does is sometimes it causes what we call as a B-clouded delirium. Means if they have a dementia and on top of that they develop an infection, then there is likelihood of having a delirium, all of that. Okay. So other than that, various other intracranial whatever causes, like you have your uremia, and see whatever else crosses your blood-brain barrier and causes things like that, that is very likely. Okay, and The other important few causes are alcohol, mainly withdrawal, and benzodiazepine withdrawal, because both of them are sedative hypnotics. They come under the same category. Okay. Other than that, other few things are the stimulants like amphetamines, cocaine. These things are likely to cause delirium. Okay. So the delirium syndrome in alcohol withdrawal is quite different from what we see during delirium with other causes. The reason it's called delirium tremens is whenever people stop alcohol, you know that they start having withdrawal features like tremors. So when tremors are combined with the delirious picture, it becomes something we call as delirium tremens. So in delirium tremens, the risk factors are higher amount of alcohol and stronger alcohols. Like see, as compared to beers and wines, when they consume more of whiskey or brandy, those what we call as spirits. So the thing is, the higher they take, the more severe the crash will be when they suddenly stop due to whatever reason. And a pre-existing liver pathology like a cirrhosis or a damaged liver, which can again cause worsening of that. Other features are previous complicated withdrawal, like it could be withdrawal of alcohol or which can cause seizures as well. So that is what we need to look for. And the mortality rate in delirium, if I combine it to both the usual delirium and the one which is seen with alcohol withdrawal, it comes to around, I would say 15 to 20%. So that's why it's important to manage this condition. Otherwise, because many people have died if it's not managed correctly. Okay, so now coming to the clinical features. So first, like I told you, there'll be loss of consciousness. Rather than loss of consciousness, there'll be alteration in state of consciousness. And orientation to time, place, person will be lost. So see, orientation to time means they won't know whether it's morning or night. They won't know which year it is, what month, what is the date, stuff like that. And disorientation to place. See, for example, we have many patients who we have met in the ICU. So what they say is they're in the bus stand or the train station somewhere, instead of saying they're in the hospital. And also disorientation to person. Means they won't recognize their own family members who come to them. Okay. That is one feature. Next one is the alteration in the sleep-wake cycle. Okay. So alteration in the sleep-wake cycle is another common thing. So usually these people, instead of sleeping at night, they'll be kind of hyperactive, stuff like roaming around the wards, trying to run away. Okay, these things. Other things are what we call as perceptual disturbances. So characteristically in delirium, they see these small animals running. See, like it could be ants or usually rats. They'll say that ants or rats, they're running on the ceiling or they're running on the wall, which nobody else is able to see. Along with that, very rarely that can be auditory hallucinations also, but visual are more common because in organic states like delirium, visual states will be more common. So other than that, there'll be thought disorders like delusion. So many a time we have people saying that the police is behind us, they're trying to catch us. In fact, one of the patients that I saw a few days back, he actually took the chair and was about to hit somebody with it. So he was stopped by one of the interns, luckily, before he could do any damage. Okay, other than that, memory problems and speech disturbances. Like I said, one is irrelevant speech. Irrelevant speech means when you ask them one question, he gives you some answer which is totally unrelated. What we in commonplace we call as irrelevance. And there's something called incoherent speech, where when the patient speaks, we won't be able to make sense of what exactly he's speaking. And like I said, in stuff like delirium tremens, there's more of tremulousness added on top of the delirium per se. Okay. So characteristically, they say there are three types of delirium: hyperactive delirium, hypoactive, and mixed. So hyperactive is the one that you usually might have seen, where they try to remove the catheter, stuff like that, and they need to be tied down forcefully, get injected with antipsychotic to help them. That is hyperactive. It's very easy to detect. But hypoactive, on the other hand, because they're usually very silent, and to the observer, it might look maybe like they're depressed or something. But when you go close to them, you try to ask them the orientation, they don't know where they are. Like they might even think it's like a bus stand and just sit there like that. Okay. So this is as far as the clinical features of delirium are concerned. Okay. And mortality, the reasons are, one is dehydration and lack of nutrition. Because see, anybody who's always hyperactive, keeps running around, obviously they can get dehydrated and can just collapse. And just, I think a few years back, I heard of a delirious patient who had actually jumped from the, I think, 4th or 5th floor of a hospital and died because, they won't know where they are. So their cognition, their consciousness, it won't be intact for them to recognize, okay, I shouldn't do this, I shouldn't do that, stuff like that. Okay, and investigations as usual, you'll have to look for your this. If you suspect an infection, whatever you think about, like CBC, and maybe if required some blood cultures or whatever you can do if you suspect an infection. Other things are oxygen saturation levels, the levels of the electrolytes, and also sugars are very important because sometimes hypoglycemia also can lead to delirium. Okay, so what happens is a delirium is still there, but in hypoglycemia, what happens because the sugar is too less, and anytime if a hypoglycemic patients they start having things like low blood sugar and all, if you feel there is a problem in the orientation, at that time you suspect a delirium. So the important thing there is treat the cause. So that's why I'm suggesting all these investigations so that you know what is wrong and you just treat the cause. And yeah, obviously stuff like RFT, and in liver problems, LFT is very important. Yeah, so these are some of the basic investigations we do. And as far as treatment is concerned, like I said, first thing is treat the cause. Okay, whatever is the cause, if you can treat it immediately, the better. Okay, then important thing is you keep the patient always oriented. Like wherever the patient is, you keep like a calendar, clock, or his family members to repeatedly come and visit him, so that will give him clues as to the orientation. See, as long as a person is oriented, he knows where he is, there is less chance of him running off somewhere or trying to do a very dangerous activity. Like I said, jumping off the floor of a building. And important is neither overstimulate nor understimulate the person. So overstimulate means avoid too much light, like you can use blinds. Maybe if it's too bright, you can just use blinds. Okay, with this, important thing is hydration in the form of IV fluids. If the patient is not able to take orally, you have to give him IV fluids. Along with that, ensure that there's adequate nutrition. Okay, so these are the general supportive measures. And we say that generally avoid tying up the patients. See, because tying up the patients and then they forcibly try to get out of that in turn can cause dehydration and all that stuff. But unfortunately, some instances where the patient is very violent, you might have to do that. But generally, as far as guidelines are concerned, they don't recommend that. Okay, so the thing is, in delirium, usually the preferred drug is haloperidol. Okay, and lorazepam is to be used only in stuff like alcohol withdrawal and Parkinson's disease. So alcohol withdrawal, what happens is, so as I was saying, alcohol withdrawal, what happens is alcohol is a CNS depressant. So it increases your level of GABA. So what happens when you remove the alcohol is suddenly they'll get more excited because your acetylcholine increases. So that time lorazepam is the drug of choice because you're substituting one depressant with another depressant, which is safer because benzodiazepines are one of the very safe drugs that we know about. They have a high margin of safety. So you give usually lorazepam is a good choice. And see, whenever a patient has a liver disease, avoid giving diazepam or chlordiazepoxide, which are the longer acting benzodiazepines. So longer acting, what they do is they accumulate that too in the liver and they can cause toxicity of the thing. So other than that, you can use lorazepam. And the one advantage of lorazepam is lorazepam has an IV IM route as well. So if you need to sedate the patient immediately, can maybe tie him down and just give 1 ampule of Lopez, that is lorazepam, or sedate him. The risk of giving haloperidol is it increases the risk of seizures because you know that in alcohol withdrawal, there's risk of seizures as well. And that in turn can lead to its own consequences and even mortality. So that is what you need to be aware of. And in Parkinson's disease, if you give a typical antipsychotic like haloperidol, what happens is their stiffness increases. See, because they have these bradykinesia, tremors, rigidity, and all of that. So that will basically be worsened if you give haloperidol. So that's why they say better to choose benzodiazepines. Yeah, but otherwise benzodiazepines should never be given because they actually can increase the sedation and lead to more problems sometimes. So unless it's stuff like Parkinson's or alcohol dependence, always choose haloperidol. And sometimes with haloperidol, we also give the antihistaminic, which is called as promethazine. So the promethazine will sometimes help in calming down the patient. So sometimes we combine that with haloperidol to ensure better tolerance of the patient. So this is in short about the delirium. Didn't want to say too much, just the important stuff.
Yes. So I have some questions which I will be asking you. And so,
Yeah.
yes, so the questions are, the first is, as you said, can propranolol cause delirium, and what can be the alternative for that? So
means propranolol in the sense, in what context are you asking actually?
supposing
Means like
migraine.
what? Yeah, but migraine, why propranolol? Because see, you have the usual drugs. See, migraine, ideally what to do is first you try your paracetamol, then your NSAIDs. So usually like paracetamol, naproxen. So 500 mg of naproxen is what we kind of give in migraine. And after that, obviously, if there are no risk factors, you'll have to choose your these ergot alkaloids like your that sumatriptan and all, which are derived from and to prevent migraine, the usual drugs are we can give tricyclic antidepressants, we can give SSRIs, and a calcium channel blocker called flunarizine. So usually propranolol is not indicated in migraine.
In general, I was telling you, if you want to use an beta blocker for any case, for any heart or something, so we have to give any alternative choice for that.
In migraine, like I said, all of that.
Normally in heart disease or BP, sometimes where you prefer beta blocker.
No. See, in those things, you can maybe use some things as simple as an ACE inhibitor, an angiotensin receptor blocker, some things like that. And also see, maybe not non-selective, that also certain good beta blockers, like you have your esmolol and stuff like that. So
yes. The next question what I have is, what is the most important feature in determining whether the patient has a delirium? For example, if a patient comes with confusion or memory impairment or anything, agitation here there, so what is the most specific symptom for that?
The most specific symptom is the disorientation. So when you talk to them, they don't know where they are, what they're doing, and irrelevant talking. So these are the things you kind of need to pick up.
Okay, sir. And so next we have, sir, how will you differentiate between a dementia and a delirium? Suppose a patient comes to you and both has memory loss at the first place. So how will you differentiate?
Yeah, see, this is a very good question, and it should be known by people. Okay, so the first thing is dementia is a chronic condition and delirium is an acute condition. Okay, and mainly the memory loss in both is caused due to cholinergic problems. Okay, so imagine it like this: in dementia, what happens is there's a slow degeneration. So slowly, all your cholinergic neurons, they'll get degenerated over the time of like few months, few years, stuff like that. But in delirium, acutely you have a shortage of acetylcholine, which will cause those kind of symptoms. Okay, and next thing is yeah, and dementia. No, you have like various causes like usually Alzheimer's dementia, vascular dementia. So the causes, it will kind of be different as compared to delirium, at least some of them. Okay, and in dementia, there won't be a problem in the consciousness till late. See, because if you see a demented person, only thing is when you do your MMSE, you'll get to know, oh, okay, he's having a problem in all of this. But otherwise, he won't look disoriented, stuff like that. He'll look very fine to you. Okay, and yeah, like I said, the memory loss in a delirium, a dementia is usually very slow. So it takes more time. Okay, like I said, also if there is dementia on top of which there is like UTI or some other infection, delirium can still occur in that. So these are some of the differences.
The next what I have is can we give lorazepam in patients with delirium? As you said, the preferred drug is haloperidol only. And
Yeah.
Delirium, Tremoncrity is in lorazepam, as you said. So yeah, that's it. So you can give it in delirium also.
Yeah. Only in alcohol and Parkinson's disease, it's better to give lorazepam. Yeah.
And next we have, is there any reason why delirium is more common at night?
Your reticular activating system. So reticular activating system is a major thing in the midbrain, okay, where you have these various things like your GABAergic glutamate, your norepinephrine, stuff like that. So there is some problem with that. And also you have your the suprachiasmatic nucleus, which is the one that controls your circadian rhythm. So they say there's some problem in the resetting thing of that. So that's why it happens. And also other reasons could be in the night. See, when it's dark, it's harder to see, right, as compared to the light. So that could be one of the causes. So that's why we call it as a sundowning or delirium. And this is also not seen in dementia, what I said.
The last question is it difficult to diagnose delirium in patients with diabetes, lactose anti-diabetic medications? Well, hypoglycemia can be there.
Yeah. See, and delirium, the thing is, if you see any person who's like I said, disoriented or talking irrelevantly and some other features of delirium, it becomes a delirium itself. Yeah, so then what you need to do is just do a sugar level. Yeah, but obviously if the sugar is too less and the patient suddenly collapses, then it becomes a problem. Yeah, so then you correct the sugars, the patient will be all right.
So we're coming to the end of the session, and so thank you so much for joining.
Yeah, sure.